Has been started.
Thank you. All right, so welcome everyone to the second Rulemaking Advisory Committee meeting for Senate Bill 822, Network Adequacy. My name is Brooke Hall, and I'm the policy analyst in charge of this rulemaking. In the interest of time today, I think we're going to forego introductions. But before we get started, just some quick reminders on meeting etiquette. Please stay on mute unless you are speaking. If you have a question or a comment or would like to speak, please use the raise hand feature and I'll call on you. If you're on the phone and you're unable to raise your hand, please just let me know and I will call on you when there's an availability. And when you are speaking, please introduce yourself so we can capture it clearly for the record. Any questions before we get started today? Karen, do you mind pulling up the agenda?
Oh, I thought I had it sharing. Hang on.
I don't see it at least.
Okay, how about now?
I see it now. Thank
All
you.
right, great.
All right, so just to recap, at our last meeting, we completed a review of the rule up to the quantitative network adequacy standard sections. Today, we're gonna review some of the comments that we received since the last RAC. We're gonna continue the rule review. Hopefully, we'll complete the review of the entire rule set today. We'll have some time for group discussion and feedback. There'll be some time for public comment. And then next steps, there is another RAC meeting scheduled for October 16th, same time as this one, 10:30 to noon. You should have gotten some materials prior to today's RAC meeting. One of them was the comments that we received since last RAC meeting. There were 3 comment letters, one from Kaiser Permanente, one from Moda Health, and one from Cambia. And then you should have also received the draft rules. Just a quick comment on the draft rules. You'll notice that there were not any changes in the draft rules since the last RAC meeting. That's not because I'm not going to make changes based on the comments and the feedback from the last RAC. I want to get through the whole rule set before making changes to the draft rule. So I will be reviewing the last RAC and then the feedback from this RAC, and then making changes that hopefully we will be able to review at the RAC in October. So that is currently my tentative plan for the RAC in October, is hopefully to be able to review an updated rule set with some changes, and then hopefully we'll have a draft of some reporting templates for you to review in October as well. So any comments before we get started, or any questions before we get started? All right, hearing none, why don't we go ahead and just go ahead and review some of the comments received. We'll start with Kaiser Permanente. So Merlene, if you're on the call, do you just want to provide just a brief overview of your comment letter?
Yes, hi, this is Marlene Converse from Kaiser Permanente. Our comment letter was pretty focused on specific components. So using health professional shortage areas for a zip code, we know that the statute allows both lists to be used for the low income zip code. We just wanted to note that health professional shortage area is a better indicator of provider scarcity and access to services than a low income zip code list. And then we're just providing the links to where those lists exist online in case that it's helpful for others on the RAC committee. We would also like to see the regulation align terminology with federal terminology. We appreciate the efforts that the OHA did for the Medicaid population, but for consistency, we think that it would make more sense to just align to the federal vocabulary and definitions so that there is clarity on what carriers are supposed to implement. And then finally, we, as you just mentioned right now, we encourage the DFR to provide the reporting standards alongside the rulemaking process so that all of the nuts and bolts of how we put together the reports are clear from the beginning so that carriers know what they're tracking and can make sure that they can then report on whatever it is they need to report on. And then finally, we know that there was discussion during the last RAC that telemedicine perhaps should not be included. And we just wanted to voice our support for the underlying statute, which does allow telemedicine to be counted as a portion of a healthcare network's adequacy. Thank you.
Thank you, Marlene. And the next letter was from Moda Health. Scott, you want to go ahead and provide a brief overview of your comments?
Sure. Good morning, Brooke. So some duplication here from the KP letter. Moda recommends aligning with federal definitions wherever possible to avoid confusion when linking certain aspects of the rule to federal standards. Moda recommended aligning with federal time and distance standards and not utilizing the Medicaid standards, again, for consistency. Also, those federal standards are ones that issuers in the commercial space are familiar with and apply to the commercial space instead of bringing in an additional line of business and their associated standards. Moda expressed concerns about health insurance issuers being solely responsible for meeting appointment wait time standards, A, during a national provider shortage, and B, just due to the lack of control from a management standpoint issuers have over provider office and factors such as patient scheduling, patient volumes, provider availability and staffing, so on and so forth. And lastly, Moda commented on the financial and operational strains caused by appointment wait time data collection, not just on issuers, but on providers as well. Again, one of the main ways to gather that data is just have to call all of the providers and try to find out what the wait time is. And that, I can't imagine providers appreciate that because you have no intention of making an appointment. We had to do this for CMS with their secret shopper program. And it's just a strain all the way around. And as well as bringing up concerns regarding overall meaningful correlations between network adequacy and appointment wait time. I still have not seen a lot of data of how that correlates in a national provider shortage and with all the other factors in this letter. And even CMS has been absolutely silent since we submitted all that data. It seemed like a data collection effort to tell them what they already knew, that there is a provider shortage, that wait times are long, that regardless if we're meeting all other network adequacy standards, you could still have wait times. Again, just depending on the specialty, on the procedure, so on and so forth. And so just kind of evaluating the actual benefit of employing standards that cause a lot of strain on issuers and providers both. So yeah, thank you, Brooke.
Thank you, Scott. And then the last letter is from Cambia Health. Antoinette, if you're on the line, can you just provide a brief overview of your letter?
Yes, good morning. I am on the line. So brief overview of our letter, similar to the other payers that commented, starting with the network adequacy definitions. We obviously recommended that Oregon align its definitions with the federal, and also recommend adding the CMS definition of urban county to ensure that all carriers are using the same definitions. And then moving on to the nationally recognized standard for annual network adequacy evaluation. We commented, this was with respect to using the annual network adequacy reporting templates. We commented that that work be done concurrently with the rulemaking so that by the time the rulemaking is completed, the templates are also ready to go for reporting purposes. So that was another of our recommendation. And then moving on, and I should have prefaced before giving a summary that our comments only reflects what was discussed at the last RAC meeting. We didn't discuss anything that was not discussed. And then moving on to the section of the draft rules that addresses the quantitative network adequacy access standards, but in particular the appointment wait time requirements, highlighting some of the implementation challenges that I think most payers are experiencing in meeting those federal requirements, and the operational challenges that we have to encounter to ensure that we meet those standards. We highlighted the challenges that we're experiencing and also taken up the DFR's offer to meet at insurers' requests to discuss those challenges and finding other reasonable and cost-effective ways of meeting that standards time requirements for this rulemaking. And then last but not least, we just had an additional recommendation with respect to the scope to just recommend clarifying that these rules do apply to the to Oregon residents seeking healthcare in Oregon from physicians licensed by the Oregon Medical Board or other appropriate state licensing agencies. I think given that it also has been expanded to apply to a large group, we think it's very important to clarify the scope within the rules as well. So again, as always, we really appreciate the department, especially you, Brooke, your collaborative approach to working with stakeholders and interested parties to achieve these rules. So thanks again.
All right, thank you, Antoinette. And thanks everyone for your comments. I really appreciate it. Are there any questions or any feedback about the comments? Great, so why don't we, oh, Melissa, go ahead.
Whoops, sorry about that. I just had a question just to clarify with Antoinette, that last recommendation about the scope. Were you intending that the word physician specifically was used? Are you saying that you would like the scope to be contained to like only medical physicians?
No.
Okay,
I'm sorry. Yeah.
Thank you.
So whoever is practicing within the, I guess, medical, so behavioral health specialist, or, so I'm sorry that wasn't clear. I just meant those, right, licensed by the Oregon Medical Board, or, so I apologize.
No
but
problem.
maybe not limited to that, so.
Thank you, appreciate that clarification.
Yeah.
And Jennifer.
Thanks. Jen Baker with Cigna Health. And I just wanted to ask, is there any way the rules can document that you're moving away from the old standards or from QHP standards into the new standards? We need that more in writing and rather than verbal guidance. Is that possible?
I'm not sure I understand. What do you mean by that, Jennifer?
If your adequacy rules are going to vary from the QHP standards and move into the federal standards, I guess we just want to know, is there any way that you can put that these are not the QHP standards that you're going to be using, or unless you are using the QHP standards?
Yeah, I mean, the intent for the national standard is to adopt the QHP standard from CMS, and then for the quantitative standards, the intent is to adopt the standards from CMS as well. And so I don't think the intent is to move away from QHP standards. I mean,
Okay.
The intent is essentially to align with federal standards.
Okay. And then for the threshold, the 90% threshold, is that in statute, or is that something we can move? Because Washington has an 80% threshold for many provider types, and so I'm wondering why we're at 90%.
That's a federal standard. That's part of the federal CMS standards. And so since we're aligning with federal CMS standards, which is a part of the statute and part of the kind of agreements that we made with insurers as a part of the rulemaking process, was to align with the federal standards. That's why the 90% is in there.
Okay, thanks.
Mm-hmm. And I thought I saw one other hand. Was there?
Oh, hey, Brooke, it's Merlene. I was wondering if what Jen was thinking about, and Jen, I don't want to put words in your mouth, but I remember at the first RAC we had talked about these regulations are being written as brand new regulations, and then the existing ones, when they're no longer needed, will be repealed. And so that would be an indicator to payers that the standard had changed when the old ones are repealed, right?
Correct. And part of the reason that we did that was because we don't want to kind of hold up or make any unintended consequences to any of the reports that are currently due prior to this rule set coming into place. So if we amended the current rule set, there was some concern that that would affect the reporting that is currently due, which is why some of the rules that are really more being amended than actually be new rules are written as new rules, if that makes sense.
Thank you. That's very helpful. Thank you.
Any other questions, comments, concerns? All right, so why don't we move on to rule review? Karen, do you mind pulling up the rule? Okay, and like I said, during the last RAC, we finished with the quantitative network adequacy section. So we're going to start with the culturally and linguistically responsive care section today. Here it is. So this is a newly developed rule which implements SB 822 Section 1A 1 large B, which requires insurers to ensure their networks include providers who are culturally and linguistically responsive to the needs of their enrollees. The intent is to improve access for communities that have been that have historically faced barriers to care, by making sure networks are not only adequate in size, but also reflect the diversity of the people that they serve. This is a short-ish rule, so I'll go ahead and read the whole thing, and then I'll take any questions about the rule, questions, concerns, feedback about the rule after I read it. So 1, each carrier must maintain a network sufficient to provide appropriate culturally and linguistically responsive care for all enrollees, including those with diverse cultural and ethnic backgrounds, varying sexual orientations and gender identities, disabilities, or physical or mental health conditions, and limited English proficiency. This language, I believe, is directly from the statute. 2, carriers must A, contract with providers who reflect the language and cultural needs of the enrollee population. B, support provider training in culturally responsive or trauma-informed care. C, ensure provider directories accurately identify provider language skills and relevant experience, training, or capacity to serve the enrollee population, including those with limited English proficiency or disabilities. 3, carriers must annually report on actions taken under this section, including but not limited to data on language access and cultural competence among network providers as required by the network adequacy reporting requirements. And then that rule will be updated once we know what the rule number will be. And then it has the statutory authority and the statutes implemented. So feedback? Scott.
Hi, Brooke. A couple questions. How is quote unquote sufficient network being defined as it's being used here? Are there percentages of appropriate culturally and linguistically responsive care or providers that need to be addressed, because we're going to have to speak to it on a network adequacy filing? So that's one question I have. And also, kind of, what does support mean in regard to provider training? Does support provider training means carriers have to administer some sort of training or provide evidence in our network adequacy report that providers that we contract with have completed said training? And then lastly, I know we're kind of stuck with the bill here, but why would provider standards in Oregon, I think, aren't there some trainings that are required as far as general provider standards in Oregon for licensure for this? I guess it kind of goes back to this requirement is falling to issuers who are not performing the care. Again, we're trying to work with providers, but we don't want to be overly burdensome to providers. And then it's also the operational strain of gathering all of this information as well. So all of that is just additional things that seem like, one, it's really important to have clear definitions of things like sufficient and support to avoid any unnecessary outreach to providers and work between issuers and providers that cause administrative hardships, and only get what we need from a network adequacy standpoint. But again, it feels like these standards could be addressed within provider licensure as opposed to just issuers having to monitor all this. So kind of the same thing about appointment wait times, basically, just some of the, what's the intent here? And we need some real standards to avoid any additional operational complexities, cost for providers and for members and for issuers.
Yeah, so to your first point, how is sufficient network being defined? Sufficient network is something that is throughout the rule set, and it isn't necessarily defined. I think it is something that during in the reporting and when the division is looking at the data and determining network access and network composition for each insurer, we'll be looking at the data provided and determining sufficiency based on, the quantitative standards and the data being reported. But sufficiency isn't defined in the rule set in relation to any of the specific rules or any of the quantitative standards. I don't know that it's defined in federal requirements either, although I can look that up.
No, that makes sense, Brooke. It seems like you could, the way it's written, when it's speaking sufficient to provide what's being listed here in bullet 1, is that you could meet other adequacy standards regarding number of providers and time and distance and even wait times. But then you also have this to they meet all that quantitatively, but not enough of them meet bullet 1 here, and therefore it puts us in a strange position when you're using something like sufficient when we could be sufficient in every other area of this bill besides this specific one, and without like some sort of quantitative number, it's difficult to ensure we would meet that, because you could meet sufficiency in other aspects and then still fail this.
Yeah. And there was no quantitative number kind of envisioned when writing this. I think in the reporting rule, there are some data elements required as it relates to this section, but they're not quantitative in number, if I'm remembering correctly. And we'll get to that section in a moment. But yeah, that's a good point, Scott, and I'll kind of circle back to that when I'm looking at the rule set. I don't think that the information in the reporting section is quantitative in nature as it relates to the data being reported related to cultural and linguistic responsive care, though. And remind me of what your other questions were. There were a number of them.
Sorry, Brooke, and if you need to go to someone else, but the last one I think we can touch on, because the other one's more abstract and will probably come up in other conversations, is what does support mean in regard to provider training in culturally responsive or trauma-informed care? I'm assuming this is not meaning carriers administering their own trainings that providers have to take, but how do we show that in a network adequacy review that we supported providers in this?
That is a very good question, Scott, and I'm going to get back to you on that one as well.
Thank you.
Antoinette, I think you're next.
I'm just, this is Antoinette from Cambia Health Solutions. Just provided an overall feedback on this section of the rules. First of all, we do support the intent, which is to improve and remove any barriers to access to care in certain communities. We think that's very, very important. And I know these provisions are in statute, but also the purpose of the rulemaking is to provide that additional guidance and clarification for implementation and operationalizing this within an organization. But overall, I mean, these are some of the requirements that I think the onus is on the provider to have, and it shouldn't be something the onus put on the insurer to ensure that the provider meets all of these requirements with respect to just making sure that they are culturally and linguistically, responsive, to care for all enrollees. We would think that this is part of the provider training, especially in Oregon, to just ensure that they meet some of these requirements. And we don't think the onus should be on the insurer to ensure that. Last but not least, we continue to be concerned, and I think Scott from MODA did emphasize on that. Number 3, we must annually report on the actions taken in this section. How are we to do that? I think sort of providing some guidance along the lines that it is really the onus is with the provider, and just ways we can I guess show that in that annual report, I think will be a step in the right direction. Again, we will submit some written comments on this with a little bit more details on that, but just wanted to provide an overall comment on that section. Thank you.
And Antoinette, just a clarifying question here. Are you saying the onus is on providers in relation to provider training in culturally responsive or trauma-informed care, or are you saying that the onus is on providers in relation to all of the kind of subcategories under carriers must?
Yeah, the training and all this categories, because we contract with every provider who meets our credentialing standards. We don't discriminate, and we cannot control who the providers actually are in terms of the multiple languages they speak, whether they have some kind of other cultural training, et cetera, et cetera. So it's really, really tough to just make sure that all of this is met. So
okay,
that's a big concern. Yeah.
Okay, appreciate that. Thank you, Antoinette.
Yeah.
Courtney? Oh, I'm sorry. I think Seth was next. Seth, go ahead.
Thanks. Seth Johnstone, Basic Rights Oregon. Yeah, I'd just like to emphasize the importance of this section and how I think it's really critical to define or have more feedback from you in the next meeting on what sufficient looks like. From our patient support perspective, we see a lot of providers, especially in our networks, or providers in our community who try to contract and have difficulty and representing specifically sexual orientation and gender identity minority communities at my organization. I think this feels a little unclear as to what sufficient would be. And we have a need for more ability to contract and providers willing to do the work. And so I think it would be helpful to hear that definition. And then in the lower components, I think the word support feels challenging here. It doesn't feel as definitive as it could be. And to B, and I think for C, ensuring provider directories accurately identify, that's been a consistent challenge, and more clarity here would be helpful in terms of what would be required to be listed in those directories to identify the culturally specific skills that those providers have.
All right. Thank you, Seth. Appreciate that. And Courtney.
Thank you. I just wanted to add that we've had under the medical board, and sorry, Courtney Dresser with the Oregon Medical Association. Under the medical board, we've had requirement for those licensed under that board. So that's physicians and physician associates and acupuncturists and podiatrists, a cultural competency CME requirement. So there is an hour requirement every year for their 4-year license. So that's for 4 years under their 4-year audit period. And that can be a lot of different things. It can be just a course, but it also can be volunteering in a specific community or in a specific country or things like that. So it's a lot of different ways to immerse somebody into that culture and to learn. And so the bill is the law is broad, the statute's broad to allow that. So so currently that, I don't know if that exists for other healthcare professions, but it does for physicians.
Thank you, Courtney. I appreciate that. And Melissa?
Yeah, thank you, Brooke. My name is Melissa Todd, and I am an independently practicing psychologist in Eugene. I'm here with the Oregon Independent Mental Health Professionals. I just have some things to say about this section that maybe would be even helpful to insurers about this. And speaking, of course, from the behavioral health standpoint, with regard to collecting data, nobody said anything about this today, but I've been present in a number of these meetings, and it's been expressed by insurers before that there can be difficulty collecting this data and that the providers are not always willing to check the boxes or provide the data on their backgrounds, particularly their own like cultural backgrounds and things like that. And I just wanted to say that I think that providing more education about why you're asking the questions would go a long way. Right now, there is a lot of distrust and concern and uncertainty because of a lot of the different things going on politically. And a lot of providers are fearful about answering those questions because they don't know what that data is actually going to be used for. So I've actually provided education to my peers myself by saying, hey guys, you should answer these questions because the insurers are asking these to help meet Oregon network adequacy standards. And they don't actually know that when they receive one of those quarterly verifications and there's just a bunch of questions, people are suspicious about why they're being asked. So I would suggest maybe providing a little bit more education about why the questions are being asked and like what that data is going to be used for, that it would be used for provider directories, for instance, to help certain groups find providers that are going to meet their needs better. I think that would go a long way. And then with regard to the piece on supporting the provider training, it is true behavioral health providers are required by licensing boards to have that training, and each one might be a little bit different, but typically in order to be relicensed or licensed in the first place, you have to have a certain number of hours of that training, and it recurs. But something that could, I think, be meaningful is if DCBS were to collect information, and this would be more qualitative on like what insurers are doing, and so having things listed in provider directories is something that I'm sure you're probably already doing. And another idea, going off of the continuing education piece, is you might offer trainings every year that are free to network providers, because one of the things that is tough is we have to pay for our own continuing education training. And if you offered some cultural trainings for free for network providers, I think that would probably go a long way, and it would be really supportive of us being able to have that training at no cost. And my organization we put on 2 trainings per year, and they're typically like 2 or 3 hours. We find a qualified speaker, we pay them, and we advertise it. And we charge a very low amount of money to try to get people to get access and to also support our organization. But I imagine insurers could do something similar at no cost.
Yeah, thank you, Melissa. I appreciate that. Jen?
Thank you, Brooke. I'm actually really glad that I went after Melissa, because I just want to add that I actually agree with most of what she just said. I think that's a really good point that she brought up about the distrust due to some of the political activity that's going on. And that's a really good perspective. And I can only speak for Cigna, but I would say working collaboratively to educate providers on why we need this information is really a valid point. And I do think my understanding is, again, from Cigna, we do put in our letters, Oregon law requires us to collect this information, but maybe we need to just add a couple sentences there on why and how helpful it is. The other thing, I don't necessarily want that to be a mandatory requirement, but I would just say it could be helpful. But what would be helpful in the rule, and what I originally raised my hand for was, again, I just kind of want to go back to what Seth was saying, and clarity in the language on what the standard is, so that we know if we are meeting it or not. I think that insurers want to be compliant. We want to ensure that we have culturally and linguistically care available to our patients or our members. And so clarifying that standard in the rule is what is going to help us get there. Thank you.
Thank you, Jen. Appreciate that. Any other comments on this section?
This is Courtney Dresser again. Just one more thing about the directories and reporting, and I'm sorry, I forgot your name, the one who spoke about the cautious about filling that out. I think there's probably some providers that are more cautious now than in recent history, especially those that serve in reproductive health care or gender affirming care, things like that. So again, that being cautious of the cautiousness on the provider side in protecting their privacy and also their patients' privacy, and there's just a lot of concern. So how we go through that is also, I think, important.
Yeah, thanks, Courtney. And it was Melissa who brought that point up. So go ahead, Melissa.
Yeah, and I really thank you, Jen, for what you said. I really appreciate that. And yeah, to continue this, I think that having it in the newsletters is great. I will also say that probably not all providers read the newsletters, and I would put it actually in the questionnaires that we get sent. I recently came upon a discussion in a group that I'm a part of. I don't know how long ago it was, the month plus ago, where there was just this huge discussion thread that blew up where people said, why is everybody asking whether we provide gender affirming care? What is this data going to be used for? And there was a lot of fear around that. And that's where I jumped in and said, hey, you know, and I gave them a little bit about my background to say I have a little bit of insight into this. But I think that if it were actually in the questionnaires where there was a little blurb there about why that information is being requested and how it's going to be used, you could collect more effective data on whether your providers actually provide that kind of care. Because there were a lot of people, it was alarming to me but I understand the fear, but just a lot of people said, well, I'm just not going to answer that question, or I'm just going to say no. And so they were actually scared enough that they would consider providing inaccurate data. So I do think provider education will go a long way, and I appreciate people's willingness to consider doing that.
Thanks, Melissa. And I will say that I think oh, Scott, go ahead.
Oh, thanks, Brooke. Yeah, thanks for all the feedback from the provider community on this. That's really helpful. I certainly agree with a lot of the statements here. I did want to touch base on one thing just regarding issuers providing provider training in this regard. It certainly wouldn't be free. I don't have a number for the cost, but just to throw it out there that administering these, organizing them, tracking the trainings for providers wouldn't be for a free cost to issuers. Not saying we would charge providers for taking the training, but I just wanted to make that clear that that would be an administrative cost. Not that I disagree with doing that, but I just disagree that it would be free for issuers.
Got it. Thanks for that, Scott. All right, so any other comments, questions, feedback? Okay. So I really appreciate the conversation on this section. I appreciate the questions that were asked. I think some of the questions will really kind of be better understood once we have a better handle on some of the reporting templates. The division has started that work, but we really needed to have a better understanding of what the rule would look like to kind of finish with a draft of some of the reporting templates. And getting through the whole rule set with a RAC was really kind of a priority for that. So I think we'll have a better understanding of some of the answers to the questions that were asked today during the next RAC when we kind of present a draft of the reporting template. But I do really appreciate the questions that were raised today, because that will help us kind of draft the reporting template and better refine this rule set. So unless there's anything else, we can move on to the next rule set. Scott, go ahead.
Sorry, Brooke, I had one more thing that was in my notes here. I believe some of this work is already being reviewed via NCQA accreditation, if I'm not mistaken. And so that may be another avenue to review, or it could be utilized by issuers to show that we do have a process for evaluating this and are meeting NCQA standards as part of our accreditation in doing so that we could use that to show that we're supporting and, have a level of sufficiency here. Just something else to throw out. Thank you.
Yeah, that's helpful, Scott. Thank you. All right, so the next rule is the network adequacy reporting requirements. This is a new section, but much of the content is carried forward from the existing network adequacy reporting rule, which is OAR 836-053-320. I'm not going to read the full rule text because it's quite lengthy, but I am going to give you a summary of what's newly required in the rule. So what's newly required? So first, telemedicine access percentages by service line. So plans must now report the percentage of access met through telemedicine for each provider type or service line. This aligns with caps on how much telemedicine can count towards network adequacy. And I would point out where this is, but if you scroll down, Karen. Oh, I think it's up. Sorry. It's right there in A. Yep. Evidence of compliance with benchmarks. So carriers must submit supporting documentation that demonstrates compliance with the federal CMS QHP network adequacy standard, which the which the division is adopting, and Oregon's quantitative access standards, including time and distance and appointment wait time standards. There is also expanded provider facility inventory data. So carriers are now required to include details on total counts of providers, geographic distribution, appointment availability, names, specialties, locations, and contacts, whether providers are accepting new patients, network affiliations, and tier levels. And this is really meant to provide the division with a way to evaluate actual provider sufficiency, not just sufficiency on paper, and to provide the division with a way to evaluate some of the quantitative network adequacy standards, including the appointment wait time standards that we talked about before. And this is an area that I'm sure we'll have conversations about in some of the meetings that we've had scheduled around how to document the appointment wait time standards. Health professional shortage areas and low income zip code documentation. So if a carrier uses an access adjustment based on a health professional shortage area or designated low income zip code, they must flag those providers and facilities, submit justification and documentation for any access standard adjustments. And this is directly from the statute, which allows carriers to make adjustments to the quantitative standards in counties that are designated as health professional shortage areas or low income zip codes. And then there is annual reporting on culturally and linguistically responsive care. So carriers must report on actions taken under the new culturally responsive care rule, including language access efforts, identified service gaps, and steps taken to address those gaps. And let's go to that section. I don't remember exactly where it is.
Yeah, I was just going to ask, where are we at?
There it is, in I. So it's the carrier's efforts to address the needs of enrollees, including but not limited to providing access in an appropriate and culturally competent manner to all enrollees, including those with diverse cultural and ethnic backgrounds, varying sexual orientations and gender identities, disabilities or physical or mental health conditions. The carrier must also describe efforts when appropriate to include various types of essential community providers in its network and actions taken to ensure culturally and linguistically responsive care, including data on language access and cultural competency among network providers consistent with the cultural competency rule. And like I said, Scott, it doesn't include any quantitative standards, but it does include data on what carriers are doing in regards to cultural competency and linguistically responsive care.
Yeah, I like this verbiage, Brooke, because it allows us to kind of tie into that NCQA conversation, and we can show what standards we're meeting, what we're doing, what we have on our provider outreach materials of why, again, like the good suggestions that were made, that like why we're doing this. So yeah, I like the actions taken to ensure that makes a lot of sense to me, and something that issuers can provide, generally speaking. Or I should say that MOTA can provide, generally speaking. I don't want to speak for all issuers with my comments. Sorry, Brooke.
No worries. And then it also requires carriers to use department issued forms and templates to report, which is something that was required previously, but I don't think was in the reporting rule. Everything else that's in the draft rule reflects requirements that were already in the prior network adequacy rules, with no major changes in substance. It just might be reworded or in a different location, but it is information that was already required to be reported in the current 320 rule. If people do want me to read the rule in full, I will do that. But like I said, it is quite long and we have limited time. So happy to do that if people would like me to. Otherwise, I'll just take feedback and comments. Melissa.
I just want to just speak on the reporting requirements here as they apply to behavioral health and say that, first of all, I am sympathetic to the insurers. This is kind of going back to the last RAC meeting as well, just talking about, the difficulty of obtaining the data on wait times and provider availability and implementing secret shoppers and things like that. Like that does sound like a lot. And I just want to point out that, behavioral health providers at this point, I think the backbone of behavioral health is still independently practicing providers, maybe some provider-owned small groups. Yes, there are some larger groups, and increasingly we are getting, kind of that corporate influx, just like medical has. But for the reason that we are independent, I think that it makes a lot more sense tracking the number of behavioral health providers in the network in relation to the number of members that carrier has. And I don't know if there's a way to estimate like behavioral health needs or to track that, like, X number of members and with whatever percentage having behavioral health needs, and then looking at how many providers in the network and how many providers per member. I think that is going to be a lot more meaningful than doing secret shoppers or trying to estimate appointment wait times. Because, like, speaking for myself as an independent provider, I might at any given time have only like 30 clients on my caseload that are actively seeking care and from me. And if I get an opening, I will have an opening for one person. And, if I get a request for at that particular time to from an insurer, I might say I'm accepting new patients, but then tomorrow somebody contacts me and I'm now full, or I might say I'm full and then all of a sudden the needs of my current patients change and then I'm not full. And it happens very, very quickly and on such a small scale. So I think it's much more meaningful to look at the number of providers. And historically, I think that in behavioral health, the limiting factors for adequate networks have been low and stagnant provider reimbursement, and then also the difficulty of admission standards, like the difficulty of going through credentialing and how burdensome is that on an independent provider. But I think that it's mostly about recruiting providers and the third thing being aggressive auditing of providers. And so it's kind of like a whole entire system that goes back to provider education again. A lot of insurance companies have increased their reimbursement due to HB 3046 and some of those rules, but I think a lot of providers don't necessarily know that. And there's a lot of secrecy around what we're being paid, and we're not supposed to talk about that or share that because it's proprietary information. But then how do providers know that they can make like a decent living being in an insurance company network? And then the other piece being, if it's really burdensome to get into the network, that can be a lot harder for independent providers. But that's just my 2 cents on the reporting as it applies to behavioral health providers.
Yeah, thanks for that, Melissa. And I'm unaware of the capabilities of, the data collection for insurance companies. So any of the insurers on the line, are you capable of providing the information in the way that Melissa described it? Which I think you said number of behavioral health providers in the network in relation to the number of members.
Yeah. And then, so that would be one. I mean, I would hope that would be a little bit more straightforward. It would probably be harder to get at, let's say the number of members that and then how many of them have behavioral health needs. I don't know if that's something that could be tracked. But, again, those kinds of numbers seem to be more meaningful to me when it comes to behavioral health.
Is that something that insurers are capable of providing? just out of curiosity.
Brooke, this is Scott from Moda. I'd want to check. Generally speaking, likely yes. I just don't want to speak for the ops teams, and then they're like, "Why would you say that on a recorded phone call?" So yeah, that makes a lot of it makes sense, and we do elements of this in mental health parity and QTL analyses as well, where we dive a little bit deeper into some of that. So yeah, great point, Melissa. But Brooke, I can check. Just don't want to give a definitive on the call today without taking it back first.
Yeah, appreciate that, Scott. Thank you. And Gail, go ahead.
Hi, I'm Gail Manasco, and I'm with BRA Society, Breast Reconstruction Advocate Society. And I know that many of this is pertaining to mental health, but Senate Bill 1137 that passed is still subject to network adequacy requirements. And so I did just want to speak to appointment wait times, that many times you do have women with active cancer who are trying to have immediate reconstruction, and you do have many plastic surgeons that have extremely long wait times that subjects the woman to go through multiple surgeries and potential complications if they have to get expanders, whereas they maybe wouldn't have if they could have gotten an appointment sooner, potentially with an out-of-network provider that's holding appointments. So I just wanted to speak to the importance of the appointment wait times when it comes to breast reconstruction and how this may work with Senate Bill 1137. Thank you.
Yeah, appreciate that, Gail. And I do want to have a conversation, hopefully, if we have time, and I think we will, about placement of some of the specialty care access requirements as it relates to Senate Bill 1137, and then some of the gender affirming care requirements in HB 2002. That's something that I've been contemplating since the last RAC meeting when you brought up Senate Bill 1137. So hopefully when we kind of get through some of the comments and the feedback about the reporting requirement section, then I can kind of lead a conversation about where to kind of and how to kind of insert some of the more specialty requirements that are in those two bills.
Thank you.
Any other comments about the reporting requirements section? Okay, well, I guess Gail led us into a perfect segue to a conversation about Senate Bill 1137 and HB 2002. Since the last meeting, I've been considering how to incorporate some of the access requirements from those two bills. For those of you who aren't aware, Senate Bill 1137 was from this last legislative session, 2025. It requires health benefit plans to ensure access to autologous breast reconstruction, including hybrid and revision procedures when medically necessary following a mastectomy. And the law specifically requires timely access and appropriate network providers for these services and limits out-of-pocket costs when out-of-network care is required due to out-of-network availability. And then there is also House Bill 2002, which is from the 2023 session. And this bill strengthened protections for gender-affirming care by requiring insurance plans to cover medically necessary gender-affirming care services, including both physical and behavioral health services. And it required carriers to maintain networks capable of delivering that care. And it also limited the ability to deny coverage based on gender markers or non-binary identity. So the question that I've kind of been contemplating is where do we need to insert into the rule set these specialty access requirements, and if so, where should they live? one option that I've been contemplating is a standalone rule focused on access to specialized treatment services, which kind of would enumerate the requirements from both Senate Bill 1137 and HB 2002. One of the kind of drawbacks to, I think, that approach is that there are many standalone rule sets standalone rules in this rule set.
Brooke, it looks like she got froze.
Yeah.
I
Oh
thought that was
boy.
internet.
I thought it was me. Yeah.
Oh boy. Okay.
Okay.
Looks like, there we go.
Okay. So tell me where I left off.
Separate rule set for standalone.
And the drawbacks, yeah.
Yes.
Yeah. So one of the options that I've been contemplating is drafting a standalone rule, which would focus on access to specialized treatment services and integrate kind of the network adequacy requirements from both Senate Bill 1137 and the gender affirming care requirements from HB 2002 as it relates to network adequacy. I think one of the drawbacks to that is that there are a number of standalone rules in this rule set, and specialty care has its own definitions as it relates, to medical services, and so it may cause unintended consequences or confusion. And again, adding another standalone rule to this already quite lengthy rule set may be a drawback. Another option that I've been contemplating is to integrate the expectations from those two rules into the quantitative standards section and the reporting rule, which are obviously more established parts of the network adequacy framework. So I'm just kind of curious what thoughts from the RAC, kind of what people would prefer, or the other option is for Senate Bill 1137 itself is to just draft a rule dedicated to Senate Bill 1137 and not have it in the network adequacy rules. Scott, go ahead.
I guess my thought about bringing clarifications in separate legislative initiatives regarding specialist care into generalized rulemaking regarding network adequacy as a whole. I do have concerns about that because, like you said, there are specific things there regarding cost sharing and other issues that now you've applied unilaterally across the board for all issuers, when those were clearly outlined in legislative intent and statute. I do not recommend applying those unilaterally for every item or service, going back to national provider shortage, going back to several issues that we've already talked about, in addition to those were specific parameters with legislative intent for very specialized services.
So Scott, do you believe that not incorporating those into the network adequacy rules and having its own rule set would be the preferred approach?
Correct, for the specific bill.
Okay. And Antoinette?
Yeah, I do agree with Scott on that approach. Given that with Senate Bill 1137, with its specialty type of care, I think having its own rule set for that bill, it's a better route to take rather than under this general network adequacy rulemaking. And of course, I don't have the bill in front of me. I was wondering, is this something that maybe the DFR can address via bulletin than a separate rulemaking? I think that may be a better path to go rather than having to convene a RAC for this, but draft a bulletin where it can be circulated to stakeholders for input, and then that would address the Senate Bill 1137 and also the requirement to address network adequacy. for that care. And Brooke, you're frozen again.
Oh, she sure is.
I apologize. I don't know why I keep going in and out. My internet must be acting up today. I was going to
Maybe
say,
go off camera, Brooke. It might save you. Yeah, that's just a rec.
that's a good idea. I will go off camera. So thank you, Antoinette. I appreciate that. That's an option I had not considered. I will say that the gender affirming care provisions from HB 2002 are addressed in a current bulletin that is active with the division. So that is an option to be considered, and I appreciate that. Merlene, go ahead.
I wanted to lend support to the comments of Scott and Antoinette about having it be its own rule set or be addressed via bulletin, just so that there aren't unintended consequences. If it is included within this rule set, we would need to look at it very carefully to make sure that there aren't unintended consequences.
Yeah. Okay. Appreciate that, Merlene. And Seth, did you have a comment? You had your hand up. I saw it go down though.
Yeah, I'm just re-reviewing the bulletin, so I'll just pass on my comment for now.
Okay. Okay. All right, I appreciate that. I am going to look into, I'll re-review 1137 and the bulletin for gender affirming care to make sure that that is addressed in there. And we'll look into whether a bulletin would be sufficient or whether we need a rulemaking for Senate Bill 1137. And I will update you on that conversation during the next RAC. Seth, go ahead.
The bulletin does infer that the department intends to provide quantifiable standards as part of future work. And so I think we were looking towards this RAC and bill to identify. So I think there is still the need to be included or in a separate rule, but there's still some missing work to be done around quantifiable standards for gender affirming care.
Yeah, I think the quantifiable standards were meant to be the quantitative standards for network adequacy. So the time and distance and the appointment wait time standards, Seth. And those were meant to kind of address the, why am I? I can't remember the term right now.
Okay, yeah, as long as the ones that we're identifying in here still apply to that care, I think that's the goal that we would have as an organization.
Thanks for that, Seth. All right, any other questions, comments? Unreasonable delay was the term, Seth. That was meant to address unreasonable delay. Okay, so now is time for public comment. Does any member of the public on the line have comment? All right. So seeing none. So next steps, like I said, the next RAC is October 16th, 10:30 to noon. The plan for the next RAC, like I said, I will be reviewing the feedback that was provided at the last RAC meeting, along with the feedback at this RAC meeting, and making some updates to the draft rule. I believe there are some meetings scheduled with insurers to talk about some of the concerns as it relates to how to provide data on some of the quantitative access standards. And so that may also change some of the draft language in the rule as well. And we also, our tentative plan right now is to provide a draft of the reporting templates as it relates to network adequacy at that October RAC meeting. So that is our plan for the October RAC meeting as it stands right now. Any last thoughts before we end? Go ahead, Bo.
Hi, I was wondering if there was another deadline for further written feedback
Yes,
given today's
thank
discussion.
you. Yeah, I almost forgot about that. So deadline for written feedback, 2 weeks. So the 23rd, September 23rd. And Jen.
Have you sent out the invite for the next RAC or no?
Karen, do you know if the invite's been sent out?
Not yet, but don't be
I just-
concerned. I'll
We
get
will
it.
send it out.
It'll go out.
Anybody else? All right, thank you all. I really appreciate your time and the conversation today. It's been really helpful. And I look forward to your comments.
Thank you, Brooke.
Thank you, Brooke.
Thank you, Brooke.
Bye.
Thank you.